Hello, Dr. Stanley.
Hello. Sorry, I'm just getting back from walking the dog.
Hey, Dr. Shalgakar, our newest sleep fellow's on for you.
Yay! Hi,
You say hi, sweet
Emma.
girl.
Hi.
Oh, well, now we
Aw.
just spit up.
That's
Yay.
so sweet.
Yeah, she's showing off her skills.
Yes, exactly. Aw,
Oh, sweet girl.
so glad she could
Okay.
join us.
I know. I was like, oh, she's awake and you just came on. It's perfect timing.
You
Perfect.
want to-
Yay.
Oh, sorry. I can help change her.
Can you guys see my slides?
Yep, they look great.
I can't see people while I am having the slideshow. So if people can just, have holler if they do have questions.
Oh,
And I feel like my presentation is relatively short, so as people are trickling in, we can wait. But yeah.
Sounds good. We can start whenever you want.
Okay. I can just get started if that's okay. And I think you guys said that you can see my slides. So, um, I'm one of the sleep medicine fellows in case people are not familiar to me at this point. I am wanting to discuss basically navigating the nexus for between sleep apnea, insomnia, and depression. And I think people have mentioned my camera is off. All right, sounds good. All right, I think I can see myself. All right, so just a little bit about me, and I kind of would give a little preface of why I chose this topic. So again, like I said, I'm a current sleep medicine fellow. I did my background is actually family medicine, and I did my training at Case Western Metro Health. So a lot of underserved exposure for underserved populations, had some exposure working in a jail, addiction medicine, and all of that. Had a great time. And then I actually did work as a family medicine physician for about a year in Cincinnati, Ohio. So a lot of my training involves being in the state of Ohio. A little bit of a roadmap for the topic, kind of going through the importance of these topics in the Sleep Disorder Center, then looking into the interrelationship of the sleep disorders and depression as well. Briefly going over the management strategies of the sleep disorders and kind of going over a brief overview of major depressive disorder. And then I want to follow it with a case that I've had in clinic, and then navigating the challenges and kind of do a brief summary of the learning points. And then on my very last few slides, have some references if people have questions. Like I said, importance of the topics in sleep disorder centers. So one of the things that made me pick these topics is that the most common referrals that we do see in sleep disorder clinic is a lot of times sleep apnea and insomnia concerns. Just a little bit of an overview. There are systematic review and meta-analysis of the relationship between sleep disorders and suicidal behaviors in patients with depression. And this systematic review and meta-analysis was published in a journal called BMC Psychiatry in 2019. And basically, the meta-analysis supports that sleep disorders, particularly they mention nightmares, but the other one is insomnia, increases the risk of suicidal behavior for patients that already have depression. So I just want to mention that that sleep disturbances from especially what we see in sleep clinic, a lot of times they do tie hand in hand with depression and then sometimes even suicidal ideations. I feel that overall, we are highly adept with managing sleep disorder breathing, sleep apnea, managing advanced PAP equipment, and even insomnia, whether that's isolated sleep disorder breathing or insomnia, or even concomitant sleep apnea and insomnia. One of the things that I wanted to touch base is, like I said, depression primarily. And the goal of my grand rounds is really having facilitate a healthy discussion of these topics, particularly in our clinic. Going over the interrelationship of sleep apnea, insomnia, and depression. Like I said, because these are the most common things that we do see in clinic, I wanted to explore these relationships. I got this diagram from sleepeducation.org, and I think it's one of the sites that we typically do use. And kind of want to briefly look at this. This is like a negative feedback loop in looking into the relationship of sleep and mental health. So it can start off as some precipitating factors, some stressors, some worries, maybe a financial loss, maybe a major life change, grief that leads to a declining mental health. And this decline in mental health can lead to poor sleep, even having insomnia. And then with the decreased sleep and poor sleep quality can lead to feelings of fatigue and difficulty focusing. And this feedback loop can make each other worse. And I think a lot of times we do see patients for example, chronic fatigue. Depression and sleep issues overall have a bidirectional relationship in that poor sleep can contribute to the development of depression, as well as depression itself can make a person more likely to experience sleep issues. And like I said, this is a complex relationship that can make it challenging to know really sometimes which came first, whether the sleep issues or the depression. Oh, my slide is not moving. Okay, there you go. So looking at the diagram, I kind of want to first start off with the relationship of insomnia and depression. So just a brief recap. Insomnia is characterized by difficulty falling asleep, staying asleep, or waking up too early. It is actually both a symptom and a contributor to depression, just like what we've talked about in our previous slide. With looking into insomnia, like I've mentioned in the previous slide as well, there's a bidirectional relationship in that chronic insomnia can lead to significant distress and impairment, leading to the risk of developing depression. And sometimes the stress and anxiety about sleep loss can lead to create a vicious cycle, worsening the insomnia. There are epidemiological investigations approximate that about 90% of patients suffering from major depressive disorder have been found to suffer from sleep disorders, particularly insomnia, in that difficulty with their sleep maintenance, non-restorative sleep, and early morning awakenings. And these were the most common subjective sleep complaint when patients with underlying depression. Interestingly, the most common subjective symptom that is being reported by patients with depression, as well as with depression, 88% of the time we do see that they're more reporting insomnia versus hypersomnia. Another thing that I wanted to point out with the relationship of insomnia and depression is that patients with major depressive disorder are 3 times more likely to suffer from insomnia than those without depression. Since the 1960s, there are some studies where they looked into PSGs, polysomnography studies, and it has shown that depression is also associated with disruptive sleep architecture. And these abnormalities typically include increase in the REM activity, as well as increase in the REM density. So that's what I have here as RD. And just to have a recap, that's a lot of times with the REM density, that's the frequency of the rapid eye movement during sleep. And these looking at polysomnography with depression, it also showed that patients with depression have a decrease in the REM latency, as well as slow wave sleep. And during REM, patients with depression often show short sleep latency, some prolonged cycles, and then, like I said, increased REM density. And then, other than looking into insomnia and depression, looking into the relationship of sleep apnea and depression, these two are also closely related in that they are also impacting each other in several ways. So research suggests that individuals with sleep apnea have a higher likelihood of experiencing depression, in that sleep apnea can cause significant sleep disruption and lead to poor sleep quality, which might contribute to the development of depressive symptoms. And then looking into the effect of mood and mental health, the chronic sleep disruption associated from sleep apnea, particularly untreated or suboptimally treated, leads to fatigue, irritability, difficulties in concentrating, all of which can negatively impact a person's mood and overall mental health. And like we've already discussed several times, looking into one big example of it is that negative feedback loop that we've discussed prior slides ago. With the biological links of sleep apnea and depression, there are mechanisms that link sleep apnea and depression. For instance, sleep apnea leads to intermittent hypoxia, which may affect the neurotransmitter pathways linked to mood regulation. The hypoxia can lead to changes in the neurotransmitter levels, particularly with the dopamine, serotonin, and norepinephrine, all of which are critical for mood regulation, and that the low oxygen levels is thought of can disrupt the balance of these chemicals and potentially leading to mood disorders such as depression and anxiety. And then looking into treating sleep apnea can often have positive effects on depression. And I think we've seen that in some of our patients, and that the use of, for example, CPAP machines to treat sleep apnea have shown to reduce depressive symptoms in some of our patients. Some of our patients report cognitive benefits with PAP therapy, in that the treatment of sleep apnea leads to a reduction maybe in frustration and feelings of inadequacy, which can be linked to depression. And improved sleep quality with sleep consolidation can lead to increase in energy, which probably can lead to some of the improvement of patient-reported fatigue that we've seen. And with the sleep deprivation and sleep disruptions, it can often lead to an increase in the stress hormones by cortisol. And by improving sleep, this can potentially reduce the stress and anxiety, which are, again, commonly associated with depression. Just like with the treatment of sleep apnea to depression, they do have a vice versa relationship, in that the presence of depression can exacerbate sleep-related problems, potentially worsening symptoms of sleep apnea and complicating its treatment. So for example, we've seen this in that depression can influence some of the behaviors and physiological factors in that with underlying depression, patients can have worsening or increased weight gain, increasing the likelihood of airway obstruction, and then even reduced motivation to seek treatment for their sleep disturbances. And just for a recap of the prior slide that we've had, disrupted sleep architecture from depression and the stress response at times we can even see from some REM rebound, or in there's increased REM activity. And then lastly, looking at the relationship between insomnia and sleep apnea. Again, this is another one that has a bidirectional relationship. I think it was first noticed by some papers since 1973. I will not attempt to pronounce it, but I think it's pronounced as Guillermino. But anyway, since 1973, there are some research publications in 1999 and 2001 looking into the relationship of insomnia and sleep apnea. And when they looked at this, they've noted that 43% of insomnia patients also met the criteria for obstructive sleep apnea. I wasn't very clear if they able to clarify whether that's with an AHI of 5 or 15, but regardless, they did mention that they did meet the criteria for sleep apnea. And as well as 50% of patients with sleep apnea, again, were found to have a significant insomnia symptoms. These insomnia symptoms, just to clarify, when they did these studies, it showed that they had a prolonged sleep onset latency from 17 minutes from patients that only have sleep apnea to 65 minutes when there is a comorbid sleep apnea and insomnia, and then decreased total sleep time to 5.6 hours from 7.2 hours, and a reduction with the sleep efficiency. So going back to this, again, sleep apnea and insomnia go hand in hand. And then just to reiterate the point, compared to people with either insomnia or sleep apnea alone, the co-occurrence of both insomnia and sleep apnea is actually associated with a greater greater impairment of subjective and objective sleep quality and quantity. I think, like I said, we're already adept with managing a lot of time sleep apnea and chronic insomnia, but I just kind of want to review that briefly. So with sleep apnea, a lot of times we do our primary treatment is PAP therapy. We can also do oral appliances. Sometimes surgical interventions are needed. Lifestyle changes such as losing weight, avoiding alcohol during bedtime, for example, and avoiding supine sleep are some of the ways we treat or manage sleep apnea. As for chronic insomnia, our primary treatment primarily involves CBTI, and that stands for cognitive behavioral therapy for insomnia. And we've looked into, with cognitive behavioral therapy for insomnia, primarily cognitive restructuring, wherein we attempt to change the inaccurate or unhelpful thoughts about sleep that patients may have, maybe looking into their unrealistic expectations of sleep time, sleep quality, and their anxiety about their past experiences with insomnia. And then behavioral interventions are something that we also do, where we also looked into with CBTI, stimulus control, i.e. bed is only for sleep and intimacy, sleep restriction, wherein we limit the time spent in bed to increase the sleep drive. And a lot of times we all, with our CBTI, we also incorporate relaxation techniques to help establish a healthy pre-sleep habits. And at times, if needed, we also look into medications as well, i.e. hypnotics, to assist with the treatment with chronic insomnia. When I did look at that study with the comorbid insomnia and sleep apnea, this 2021 clinical paper mentioned that there are studies that they've used isoprene, particularly 3 milligrams, and that it has shown that there's an increase, it increased the respiratory arousal threshold, and it actually improved the obstructive sleep apnea severity. So probably when they looked into this, that patients have less arousals with treatment of this medication. And that when the study have mentioned that there's particularly consistent reductions in the AHI in people with the low arousal threshold with this medication. They also looked into another medication, zopiclone, and they look at 2 different doses, 7.5 and 15 milligrams. With the 7.5 noted, some studies noted improved the respiratory arousal threshold, but did not change AHI. And then surprisingly, a higher dose of this medication, zopiclone, had no effect on the respiratory arousal threshold or the AHI. And then there are a few randomized placebo-controlled trial where they said even zolpidem, zolpidem 10 milligrams, reduce the respiratory arousal threshold, and it actually increased the objective sleep efficiency by 10%. And with this, overall, the theme for the hypnotics when patients have comorbid insomnia and sleep apnea, there is actually more of a mixed evidence. They did look into CPAP with comorbid insomnia and sleep apnea. And then a lot of times, and I think we've seen this in clinic, CPAP does improve insomnia symptoms among some of the patients, but also we do see that PAP therapy is also commonly rejected and poorly tolerated by patients with comorbid insomnia and sleep apnea compared to those with just sleep apnea, for example. And patients with insomnia who already experience difficulty with falling asleep would find it even more difficult to relax, accept, and get used to a pressurized mask on their face compared to patients with sleep apnea alone. Looking into CBTI for patients with comorbid insomnia and sleep apnea, CBTI may be useful in patients prior to initiating CPAP therapy. Although some studies have noted that there's improved adherence improved CPAP adherence following CBTI. However, again, other studies have noted that it's really just mixed evidence, and starting CBTI before PAP therapy or doing PAP therapy first, and then if persistent doing CBTI, none is actually better. And that is a consensus that I've seen with comorbid insomnia and sleep apnea. Since sleep apnea, insomnia, and depression are often interrelated, one of the things that I wanted to look into was, is there like a one size fits all that can address all three, since they're frequently related or found existing whenever we do see patients in clinic. I did not really find one, but primarily maybe what's better instead of a one size fits all is looking into a coordinated treatment approach, looking into all of this. So for example, treating sleep apnea often improves sleep quality, and it can often alleviate the symptoms of depression and insomnia. And sometimes by managing depression, it improves the sleep quality and overall reducing the severity of insomnia. But there's really no one size fits all. But a lot of times, if you address one, the other comorbidities also actually do get better.
Well, I have a quick question. What about did you find anything that showed kind of the order to address things? Like
with sleep apnea, depression, and insomnia?
Insomnia, yeah. Because I think, like you're alluding to, that's oftentimes, and especially since there's always a delay between trying to address each one of these areas.
Right. I did not really see if there's a specific order. And I think that's a very good question, because we do see a lot of the times they're always together. I did not see a specific order. And I think the treatment that I've seen looking into this is that by treating one of them, what's really the primarily distressing factor is that a lot of times the other two gets better. So that's kind of how they phrased it.
Good. Thank you.
Let's see. All right. So like I said, I think we're fairly adept with managing insomnia and sleep apnea. So I kind of want to look into really just briefly looking at management strategies for major depressive disorder. So just for a recap, in order to diagnose major depressive disorder, i.e. unipolar depression, is that the episode has to last for at least 2 weeks, and that patients would have 5 or more of these symptoms. And if you want to, you can look into on the right-hand side where this is a snippet of the DSM-5 TR criteria. So 5 or more of these symptoms would include depressed mood, anhedonia, insomnia or hypersomnia, changes in appetite, some psychomotor retardation or agitation, low energy, poor concentration, thoughts of worthlessness or guilt, or sometimes recurrent thoughts about death or suicide. And at least one of those symptoms would have to be depressed mood or anhedonia. So just for the recap, the one that I highlighted on the bottom, the depressed mood and the anhedonia, those are our PHQ-2 questions that I think we typically do ask whenever we do have concerns for sleep apnea. For a major depressive disorder. And that when we do screen patients for this, 3 or more would prompt someone a score of 3 or more will prompt someone to proceed with doing a full PHQ-9 if it does show a positive PHQ-2. And just for a recap, in case we forgot what PHQ-9 is, PHQ-9, we ask in the last 2 weeks these questions. So the first 2 rows where it says anhedonia, little interest or pleasure in doing things, and then feeling down, those are the PHQ-2. And if it's positive, at least 3 for the score, we proceed with a PHQ-9. And these are the questions we ask. Trouble falling asleep or staying asleep or even sleeping too much. Feeling tiredness, poor appetite, feeling bad about yourself, feeling guilt, feeling like they're a failure, trouble in concentrating, maybe moving or speaking too quickly that somebody may have noticed, being fidgety, restless, and thoughts that they're better off dead or hurting themselves in some way. And then depending on the frequency in the last 2 weeks, it prompts us to look into 0, i.e. none of that symptom, several days, more than half the days. And then if it's nearly every day, that's what prompts us to score a 3. And then we add all of these answers together, and greater than 10 is more likely major depression, 10 to 14 moderate depression, and then 15 to 19 moderately severe, and greater than 20 is considered severe. Just a brief recap on how major depressive disorder is primarily treated. I don't want to spend a lot of time on this because I know we don't really handle the pharmacologic therapy for the major depressive disorder, but at least having some familiarity with it would, I think, be helpful. And that's why I provided more information about the assessment for the severity and how we typically would diagnose sleep apnea. I mean, sorry, major depressive disorder. So the initial treatment primarily is a combination of pharmacotherapy, whether that's SSRI, SNRI, or those atypicals, or even antipsychotics. And that typically in combination of pharmacotherapy and a psychotherapy, typically in combinations is more effective than either treatment alone. And that if someone is still having basically a resistant unipolar depression, despite being on pharmacotherapy and psychotherapy, a lot of times there's a consideration to use transcranial magnetic stimulation. And that's the picture that I have here on the right. And it's a procedure that uses magnetic fields to stimulate the nerve cells in the brain to improve symptoms of major depression. Just to highlight, with the transcranial magnetic stimulation, it's not the same as electroconvulsive therapy. But with severe resistant unipolar depression, that is something that can be considered by psychiatry. And that more recently, they've also looked into and has started using ketamine or esketamine for non-psychotic, non-catatonic resistant depression. I kind of want to demonstrate a case wherein I had a clinic patient looking into the complexities of the patient with all 3 conditions: sleep apnea, insomnia, and depression. So I know this is a very busy slide. So this was a 60-year-old patient with a history of high blood pressure, TIA, mood disorder, i.e. mixed anxiety, depression, some obesity, and following up primarily for their insomnia and their sleep apnea. They had a 2018 home sleep apnea test, and that they had an REI of 41, O2 nadir of 83%, had a titration study at that time, and weighing 202 pounds at that time. And they mentioned that CPAP-9 was effective in treating their underlying sleep disorder breathing. And after their studies, they were referred to our multidisciplinary insomnia clinic in 2022. Because of their persistent insomnia with underlying sleep apnea. They did note that patient has underlying anxiety about going back to work, some financial concerns, depression that started since his divorce in 2022, so years back. At that time, his BMI was 33, and then he mentioned that he has been having difficulty falling asleep and staying asleep for 30 years, so over half of his life. Looking into his sleep schedule at that time was 10 o'clock. And then wake up would vary between 6 a.m. to 10 a.m. His sleep onset latency was also varying between 5 minutes, but 50% of the time, he says, it's around 3 hours. And they did not mention his frequency of nighttime awakenings, but overall wakefulness after sleep onset was ranging between 1.5 to 2 hours. And he approximates that his total sleep time was around 6 hours. His PHQ-9 was falling into moderate to severe depression with a score of 15, and with the GAD-7, that's a screening for anxiety, he was scoring 12, which places him under moderate anxiety. With the multidisciplinary insomnia clinic, he had no prior hospitalizations or suicide attempts. His PAP download showed intermittent use of his PAP device, wherein out of the 90-day period, he used it for 5 days greater than 4 hours, and his average use was primarily falling into 6 hours if he does use it. Leaks in PAP-generated AHI were within expected limits. At that time, when they evaluated the patient, they said that his sleep onset and sleep maintenance were from insomnia were from multiple factors. He did have poor sleep hygiene. With variable wake-up times, he was having frequent, noted that maybe some frequent daytime napping, and that his mental health was suboptimally treated with reported some flashbacks of his motor vehicle accident. He had a motor vehicle accident before seeing the multidisciplinary insomnia clinic in June of 2022. And since then, he reports that he would sometimes have flashbacks. And then with the suboptimally treated mental health, underlying sleep hygiene, and poorly or more on untreated sleep apnea, they said that he's a good candidate for CBTI. Continue with the trazodone that was being managed by PCP. And for his obstructive sleep apnea, education was primarily given, and that they've mentioned to continue with his full face mask, given that he had issues with mouth venting. 6 months later, after that, he had a follow-up visit with in the clinic. From BMI 33, he was BMI 34, still had poor compliance, although increase in his PAP use from 6 out of 90 to 18 out of 90, as we can see here. His average use was still around 6 hours and still within CPAP of 9. He reports that he has still not established with the cognitive behavioral therapy for insomnia sleep medicine, behavioral sleep medicine team, because he said that since his motor vehicle accident, wherein at that time he had a TIA and he had to be in rehab, he reports that he's unable to use his PAP equipment because during that period in rehab and his hospitalization, he wasn't really given his CPAP. And then he had, since that period, he has a lot of appointments wherein he was seeing physical therapy, speech therapy, and he wants to prioritize this first. And the plan at that time was, let's have a mask refit, because it was noted that his AHI from his PAP generated data was slightly elevated, mask refit, and continue with CPAP 9. And because he was having suboptimally treated mental health, to hold off with CBTI and optimizing his mental health first. Just for completion, he has no really significant allergies other than the penicillin, wherein he's having anaphylaxis, but no other drug allergies. He is on mood medications, Paxil 40 milligrams, Elavil 100, trazodone, melatonin, He is on antihypertensive medication, losartan. His surgical history is non-contributory. Social history, really just alcohol use 3 to 4 times per week, but not really binge drinking. And by the time I've seen him, his PAP generated data has also improved, 16 out of 30-day use, wherein although his averaging use was around 2.5 hours, PAP generated leaks and AHI were otherwise within expected limits. When he saw me, he reports that since his motor vehicle accident, he was having ruminating thoughts about that. He had a lot of financial concerns because he has lost his job and that he is no longer working. He has lost his income. And then he told me last week his dog died. He reports that his sleep is poor. He is approximating his total sleep time, maybe 7 to 8 hours, but it's quite fragmented, wherein he is sleeping for 2-hour chunks, relatively close to his prior sleep schedule, but this time bedtime around 12, wake time around 10. So that will put him around 10 hours. But with his frequency of nighttime awakenings, he thinks it's more of 7 to 8. Sleep onset latency varies between 30 minutes to 3 hours, and he would occasionally wake up earlier than his expected. He was refitted from a full face mask to nasal pillows, and he has no issues with that. He reports difficulty initiating sleep and staying asleep with his insomnia. He was quite anxious, depressed, tearful. He was sobbing uncontrollably. He reports that he lives by himself and he is divorced and he does not remember the last time he saw a therapist. And he reports that I feel like I am a fish that's out of water and I do have dreams that I am better off dead. I would want to ask if people have any questions or concerns so far and how I would say they would typically manage a patient like this in clinic.
Yeah, I'd like to hear from others. I mean, patients that we see often have this kind of suicidal ideation. The question becomes their safety and risk for acting on that, and that's a complex calculation made up of a number of different considerations. But that's obviously the immediate concern there when you start hearing about thoughts about wanting to be dead.
Thank you. Thank you, Dr. Arnett.
Roma, I had a case at the VA, so a little different than maybe how it would work at the U, but they had a warm handoff, I think it's what they called it, via their computer system. And so while the patient was still like in the clinic, we were able to get in touch with like a licensed, I guess they were a therapist. I guess I don't know exactly what their title was, but some sort of mental health professional who, after we were done kind of trying to address the sleep related needs, did chat specifically regarding the mental health concerns that were brought up during the visit with the patient, and then helped us kind of determine was he safe to go home, like, or do we have to like do more of an emergence referral to like the emergency room or a hospitalization of some sort. But that very well might be pretty unique to the VA.
Yes, no, thank you for pointing that out. Yes, I do think a lot of times we do see more of these types of patients at the VA, but I don't think at the U we're really exempt from this. So I'm glad you pointed out warm handoff. It's like one of my favorite things. And with Dr. Arnett doing safety planning. So moving on, I can tell you what we actually did in clinic. So I was very nervous, but just like what Dr. Arnett said, we actually assessed his suicide risk. So looking into his passive suicidal ideation, his wish for maybe more of escaping his reality, thinking about the frequency of having of this thoughts of being better off that and how long he's been having this, looking into his intent and what kind of method do they plan to commit suicide, for example, and what kind of access do they have if they are going to attempt to do this. I also looked into risk factors. So things that are global risk factors that can increase the risk of someone having basically increased risk is that if they're having ideations, plans, if patients are feeling trapped, having hopelessness, more withdrawn, if they are isolated from friends or family, if they do have some global insomnia, major life changes, negative life events, alcohol use, substance use, all of these things are increased risk factors. Or in even prior attempts. I think that's the biggest one, prior suicidal attempts. You also want to consider during that appointment, we actually looked into homicidal ideations or plan, i.e. trying to harm other people. What are their thoughts on that? We also assessed gun safety if he has access to that. And one of the things that we actually did in clinic is having a safety planning wherein letting him know the 24/7 psych emergency services, the actual hotlines for it, what's the local number, if there are friends or family that he can call when he's having this negative thoughts, and worst case scenario, really keeping himself safe and going to the nearest emergency room or dialing 911. And then I think Dr. Arnett included a helpful acronym for assessing risk factors, and he has attached it in the chart. Other things to look into when assessing suicidal risk, intent, risk factors. We also want to make sure sometimes looking into protective factors, the impact of friends and family, sometimes religious belief. If they have a sense of purpose, if they have a strong support network. So sometimes when patients are involved in church, having those church connections, life satisfaction, and like I said, overall, looking into their access to firearms, for example, and having a safety plan. I think because we also do a lot of multidisciplinary insomnia clinic, this is one of the dot phrases that you can look into to help you have a psych safety assessment that I think is helpful. And I did look into that. So just to recap with that plan, with that patient with his still suboptimal use, one of the strategies that we did do in clinic is that we tried to look at it in a more positive approach, recognizing his efforts from 6 out of 90, 18 out of 90 to 16 out of 30 days of PAP use. And that briefly looked into the encourage him to use his PAP more frequently and throughout the night. We continued his pressures, refilled his supplies, and then for his chronic insomnia, I actually did send a message to one of our behavioral sleep medicine folks and give them a debrief of what's going on with the patient and see if they could actually see the patient sooner and maybe more of a one-on-one. And luckily, one of the things I did mention during that visit when I saw him is that he was going to be seeing his primary care physician tomorrow. And as for his anxiety, depression, PTSD, we did have a safety plan. His social worker is calling him every single day to make sure he is okay. And one of the things that we also did was motivational interviewing, as his social worker has given him numbers or contact information to follow up and establish with a mental health therapist. And one of the things we did was with motivational interviewing is to actually for patient to make attempts in establishing care with a mental health therapist. So as you can see with that kind of example, some challenges in an integrative treatment is that you need to have coordination between specialists. So a lot of times you have to involve primary care, behavioral sleep medicine, if for their insomnia, even psychiatry, a lot of times, social worker, maybe for concerns, if you're, let's just say patients at home and you have safety concerns, maybe even social worker, even police for a safety check. And managing patients with non-compliance in a multifaceted therapeutic approach is really looking into shared decision making and that what is important for the patient and how we can meet them halfway. And then sometimes being more flexible and maybe adjusting with short-term versus long-term treatment plans. When I had that patient, the challenges that I thought were a lot of times we do have patients that are self-referral, i.e. we don't know if they have a primary care, or a lot of times they said, I don't have a primary care, I'm not established because there's long wait times. Other challenges when patients have a comorbid sleep apnea, insomnia, and then depression is that there's long wait times for psychiatry or even availability for mental health therapists. Some of our patients with uninsured or maybe Medicaid would have insurance limitations. And Josh already alluded to this. I'm not familiar at the University of Michigan, but at the VA, I do think I was able to do some warm handoffs, but a lot of times warm handoff is easier when you have both mental health therapists and also yourself being in the same vicinity. Warm handoff, if people are not familiar with it, is that it's primarily an integration between behavioral health services into your clinic. And it gives you an opportunity to introduce the patient directly. And this increases the chances that patient will actually participate in mental health services. The other thing is time. How long does it take to actually address sleep apnea, insomnia, and then even depression? This is already a comprehensive sleep center wherein we're handling a lot of complicated things, referral from other sleep centers, and it's very time consuming. And one of the things I ask myself as well is that if a patient reports active suicidal ideations and plan, I am unsure what I would need to do, but likely I would call a psychiatry at that point if I can. And then with other challenges with patients that have sleep apnea, insomnia, and even depression, is that I was able to kind of look is how many the number of qualified behavioral sleep medicine therapists are in the US is overall fairly limited. At least in the Society of Behavioral Sleep Medicine, I was able to find 6 registered under the state of Michigan. So that's not a lot, state by state. And then at times, people would have to use digital CBTI. I think overall, for the sake of time, I think these are the main points I wanted to address. The learning points that I have is that there's an interconnection between sleep apnea, insomnia, and depression. And like I said, each of those are complex and have a bidirectional relationship in that each condition can influence and exacerbate others. There are physiological and psychological links between all these 3, and that they all impact the quality of life and daily function. It's complex to manage all of this, and that we have to recognize that this can be a multidisciplinary approach when we're trying to handle all 3. And then we do have to be a little continuously learn and adapt with the treatment strategies moving forward. And yeah, I want to give people a chance to ask questions.
Roma, great job. I just wanted to pipe in about, you guys brought up a couple times what we would do with the U. So there is a psychiatric ER there through the U, and if you put in an order for, I think it's psychiatric ER, so if you're in Epic and you type psych ER, there is a order that comes up that also includes the phone number to call. And so then you can directly call them. You'll speak with a charge nurse or a social worker, and they walk you through the next steps. It's a lot simpler if the patient is going to voluntarily go to the ER rather than if you're like involuntarily detaining them, but that's getting to a broader topic. But if anyone's there at the U and isn't sure next steps, that's a great resource. I also wanted to just point out, so I think it's great that you're bringing up this topic of depression. So like talking about other medical conditions and how they interact with sleep conditions. I will say this is a very relevant topic to come up on your guys' sleep boards for the fellows here, is just any sort of other medical condition, how does it interact with our sleep conditions? And depression is very much a fair game sort of topic. While Roma did bring up the most common of the associated ones, so just insomnia, highly associated with depression, and then OSA is also just very common nationwide. Really, every category of sleep medicine has some sort of condition associated with depression, so it is worth just reviewing that as well, because especially when you consider the mood management medications we use for depression, now we're talking about potentially provoking RLS symptoms, so within the movement category, or parasomnias. Also, depression is relatively strongly associated with certain circadian rhythm disorders. I do recommend going to the ICSD-3 and like in each of those sections, so they have a clinical features and then I think it's associated features section. Do read through that because a lot of them will mention depression as an associated feature, and that sort of thing is also fair game to come up on boards. So in particular, delayed sleep-wake phase disorder, the non-24-hour sleep-wake disorder, those would be associated with depression as well. So anyway, I think this is a nice kind of intro to getting you guys thinking about that and reviewing that sort of material.
Thank you, Dr. Stanley. And I think Dr. Vijay Kumar actually asked the same question about if there's basically a social worker we can call when these things happen. So thank you for that information.
I had a question and comment. Thank you so much for talking about this. It was a great talk, really relevant. Just to second what Dr. Vijay Kumar was saying, I think she's asking whether we do have a social worker. And I think that's a great question. Your talk highlights the importance of this and relevance to all of our patients, but I would be curious about what that system is for sleep medicine and if that could be improved. My understanding is that we don't have a warm handoff process, and that perhaps that's something we can look into. I know I've talked to the fellows in my workshops about what we do in these situations. So highlighting the need for that. And also just a comment in your case, you had mentioned involving behavioral sleep medicine, and this is a patient with active suicidal ideation and unmanaged psychiatric disorders. Sometimes we wouldn't be the next stop on that. We would actually refer them to psychiatry as well. And I get concerned that the patient would have to wait even longer. So
thank you for pointing that out, Dr. Conroy. Yeah, good question. No, I actually looked into the patient. So one of the things that I felt was behavioral sleep medicine was very, very helpful is that I think I've had this with you, Dr. Conroy, is a lot of times you guys are able to have some community resources that can able to see the patients sooner, for example. And I think that was something that I think I picked up. A lot of times when we refer patients for at University of Michigan or maybe affiliated with University of Michigan, I think the wait times can be, I think the shortest I've heard of was 3 months. And this is not going to fit with a patient that is having, even though passive suicidal ideations. Luckily for this patient, he was actually already plugged into social worker. So like I said, his social worker actually has been calling him every day and he was already given a list and he really just actually need to push the buttons and having the energy and the motivation to actually get established with a therapist. Something that I thought was really helpful is that I think I sent an SOS with one of the behavioral sleep medicine team, but you guys were able to actually have a one-on-one sort of follow-up appointment with him within a couple of days. And then he was actually seen by psychiatry, I think within the week of that, because before he was not established with psychiatry. And then lastly, I think you've mentioned about the social worker. I do believe we do not have a warm handoff, but I've referred patients to social worker in the past, and I think there's an actual order set from University of Michigan, and it depends what you're looking for, that you're looking for assistance with social worker. And I think there's 4 of them, and they're gonna walk you through which order to put if you're looking for financial services or maybe questions about insurance. Is it access to mental health? Those kind of things. I think they would have that in the social worker smart set. And I think Dr. Goldstein just mentioned there is some scripting for suicidal ideations that she can help and forward it to people. And I want to be respectful of people's time. Any other last minute questions?
No, that was fabulous, Roman. You obviously hit on a really important clinical scenario. So thank you for this excellent presentation. That was great.
Thank you, Roma. Perfectly appropriate given May is Mental Health Awareness Month.
Oh, I did not know that.
Very apropos.
Excellent.
All right.
Awesome. Thank you.
Thank you, everyone.
Great job, Roma.